Hi, I'm Monica Gonzalez, Diabetes Care and Educator Specialist. I'm pleased to share my case study number 3. It's about how to decrease hypoglycemic episodes by transitioning from patient from insulin sliding scale to insulin carb ratio system. This 68 years old female has low literacy and she was complaining about frequent hospital visits due to hypoglycemic episodes. She was treated in a primary care facility. She couldn't have access to endocrinologists. And the pillars to reach targets, A1C targets, were the following. We had a good team communication to increase basal and bolus and doses to get rid of clinical inertia. The second pillar was she had frequent support online and in-person sessions, at least 12 sessions per 3 months. Third, she stopped insulin sliding scale system and implemented an insulin carb ratio system guided by a diabetes educator to cover mealtime doses. We applied the concept of equity of care by using a handout to apply insulin carb ratio techniques, which is a handout designed on patient needs. Easy to read and easy to follow. They don't need to use calculators or read labels. They just need to be accurate with portion sizes and add different units for different foods. And the fifth pillar is that this patient was on multiple daily injections, 1 basal and 3 to 4 boluses a day to cover meal times. This slide gives you a review about what happened with A1C and BMI patterns throughout the last 10 years and shows what happened with a basal and bolus regimen titration in the past 5 years. She was on control for the first 7 years when she was following insulin sliding scale system. Plus, she was using only 1 basal injection per day with hypoglycemic episodes as well, with recurrent hospital visits. After we introduced bolus doses with insulin carb ratio technique, she was able to maintain a perfect A1C for the next 4 years without hypoglycemic episodes. She did try a CGM at the beginning, but she didn't like it. And we were collecting blood sugars verbally from her. To maintain those perfect A1C numbers for 4 years without hypoglycemic episodes, we use a resource adapted to her needs, especially that she was a low literacy patient, and we did implement the insulin management guide, which is a tool to match insulin to food. A basal dose was decreased from 30 to 25 a day after we start the introduction of bolus doses. Bolus dose adjustment was a little more tricky because initially she was following insulin sliding scale using about 20 units per meal or 30 per day based on her pre-meal blood sugars numbers. But she was not using any insulin to cover carbs for mealtime dose. She was using 30 units of bolus per day, representing about insulin carb ratio of 6. But we increased the ratio to 10 to provide about 20 units of insulin per day rather than 30. The final prescription was 25 units of basal dose and 20 units of bolus dose per day to maintain those perfect A1C numbers for the 4 years without hypoglycemic episodes. Then she had a relapse because she had a relative death, plus she was out of the country for a few months. But recently she was she has been able to restart regimen again after her relapse, and now her A1C is back to 8.6. The lowest BMI has been 19 throughout the years, but she has been able to keep it in between 20 and 21. To fix hypos, we make sure she was always injecting bolus doses 15 minutes before the meal and not after. We adjust bolus and basal doses based on physical activity. We were decreasing 2 units to basal dose on those days that she was walking. And we make sure that she was following insulin to food system correctly, which is the insulin carb ratio with the support of insulin management guide tool. She never used calculators or read labels to find out the units of insulin, because insulin management guide does it for her. IMG was one of the main reasons she was able to maintain A1C, perfect A1C for years straight. She started regimen on table 3, insulin carb ratio of 7, because she was originally injecting 10 units per meal. Table 3 gives about 10 units per meal to cover 45 grams of carbohydrates. For example, 3 tortillas, half a cup of beans, and 1 fruit gives about 10 units per day. But she was still experiencing hypoglycemic episodes, and we decided to lower it down to table 2B, which is ratio 10. It's about 7 units per this to cover same plate of 45 grams of carbohydrate. To reach perfect ratio, she had to try 5 more levels of titration from level 7 to 10. That means to cover the same meal, she has to use less units from 10 to 7 units per plate. The following 2 levels were giving her about 9 units per meal. Is table 2D or table 2C. And the last 2 levels she tried was giving about 8 units per meal that represent table 2B or table 2A. The last level we use is table 2. Insulin carb ratio of 10 gives 7 units per meal, which represent 1 unit per 10 grams of carbohydrates. We explain the back of the handout as well frequently to help the patient how to correct blood sugars when blood sugars were high or low before the meal, using correction factor of 150. We were supporting her with rule of 15 to recover from hypoglycemic episodes. And we did explain to decrease 2 units when using a fatty meal or when having blood sugars under 100 before the meals to prevent hypoglycemic episodes. Basal adjustments while walking 30 to 20 minutes a day, where we did decide to decrease 2 units to the basal dose. We explain foods that don't need carbohydrates, so don't have carbohydrates, and that don't need insulin as well. This slide shows all the automated insulin delivery devices available for providers and their patients, like smart pens, insulin pumps, and the bionic pancreas, just to mention some. Currently, we are facing gaps in diabetes care because not all the patients have access to automated insulin delivery devices. And we all know that carbohydrate counting and reading labels is a challenging task for people with diabetes on multiple daily injections. And based on that need, I create a great tool to explain insulin carb ratio system to our low literacy patients, which is Insulin Management Guide. We have been testing it for more than 100 patients in the past 3 years, and we are looking for funds to formalize research and expand this tool to all health practitioners doing bolus titration or mealtime titration. All the algorithms present in automated insulin devices are the same algorithms present in insulin management guides. Insulin management guide includes 32 levels for bolus titration and includes 64 food choices to choose from, includes correction factor and rule of 15 to recover from hypoglycemic episodes. By matching insulin to food correctly, IMG prevents hypos and prevents weight gain. Insulin Management Guide has been helpful to decrease clinical therapeutic inertia, which is the inability to move on medical treatment. My last slide have some conclusions on case study number 3. It has recommendations for diabetes care providers on cases to prevent hypoglycemic episodes. The first one is good team communication and ICR implementation were the key to remove clinical therapeutic inertia. The implementation of equity of care concept by using a resource adapted to patient needs, IMG, help to overcome barriers always present in diabetes population. Frequent education visits, 12 visits every 3 months with the diabetes educator, a specialist, provides enough support to guide patients in regards of insulin titration in conjunction with provider supervision. Insulin carb ratio implementation can decrease hypoglycemic episodes. And my last recommendation, when patients gain or lose weight or increase or decrease exercise, we need to adjust a basal and bolus doses to prevent hypoglycemic episodes and still reach A1C targets.